Welcome everybody to another VITA Learning webinar. Today we have Dr. Julian Conejo. Hi Julian, how are you doing?
Hey Jim, I'm doing well, thank you, and thanks for having
me. All right. Oh, so welcome. You're a very knowledgeable clinician that also does lab work, and the way you explain things and help all of us understand more about the different technologies today, about your update, in a sense, what you're doing with digital dentures, what you're not doing with digital dentures. Can be a very exciting webinar today.
Yeah, absolutely.
So just for those of you who are joining us, I just want to let you know that your phone is on mute. So if you have a question at the end of the session, we're going to do Q&A. On the right-hand side of your screen, you should see the GoToWebinar, like a panel, and under that there is a question area. Just click on that and then type in your question, send that away, and then at the end of the program I will ask Dr. Conejo about that. So your phone is on mute. Use the question box. Q&A will be held at the end of the program, 10-15 minutes or so. The workshop itself is recorded, so you can find the recording as well as other webinars that we've done with Dr. Conejo throughout the year and last year on our website, VITA website, VITA YouTube channel, North America YouTube channel. So just give us a couple days and that will be posted. So today, digital denture updates, understanding progress with Dr. Julian Conejo. Dr. Conejo obtained his doctorate from the Universidad Latina, Costa Rica in 2005. Completed training as a prosthetist at the Universidad Intercontinental Mexico 2008. He's a visiting scholar at the Department of Preventative and Restorative Sciences, University of UPenn, Philadelphia. Practices clinical dentistry and conducts extensive research at UPenn. He is currently the clinical CAD/CAM director at UPenn, and from his research and experience has written several peer-reviewed articles and studies, lectured worldwide, has helped us out tremendously with a lot of webinar information, articles as well. So welcome, Dr. Conejo. I'll let you take it away when you're ready.
Perfect, Jim. Thank you so much again for having me. Can you just confirm that you are able to see my screen, my slide? Okay, now.
All right, so just show your screen and you should be good to go.
Okay, give me 1 second. So I see my screen, but I don't see my mouse.
Yeah, it says waiting to view Dr. Conejo's screen, so I think he's that window, that icon that shows show screen.
Show my screen. Mm-hmm.
Yeah.
Okay, and
excellent.
Then just let me hit play here. Okay, now can you confirm, Jim?
Yep, we are good. We see your first slide. So okay. All right, so I'm gonna bow out and let you go at it.
And we get going. Okay. Well, thank you once again, Jim, and the entire team from VITA North America for having me today with you guys for this webinar opportunity. And today we will be focusing on the edentulous patient. And I would like to give an update, as Jim said, of what are we doing or what maybe we're not doing yet, and understanding, as we see here in the title, the progress and certain limitations that we might still face with the digital process of treating the edentulous patient, whether it's with a removable or a fixed prosthesis. So we understand that dental implants are used worldwide in in a high percentage of edentulous patients, but we also know that there are many patients within this group of edentulism that might not have the possibility to go through a surgery and get the implants placed. So we still have the challenges of tissue-supported edentulous patients. So this is what I would like to focus today on, both solutions, because as I always say, we cannot choose, right, the patients that we are going to be treating and seeing, and we got to be prepared for both scenarios or for both challenges. So when we start thinking about doing high complexity full arch implant cases for the edentulous patients, I think that this is what we want to visualize, right? We want to have a perfect relation between the prosthetic element and the foundation, which are those implants, a perfect framework that fits accurately on the abutments, and a material over that framework then can have a good function, aesthetics, and could provide the patient with that ability of chewing as it was before losing the teeth. So this is our goal in many of the cases, as I said, but also we have some patients that can be medically compromised, or patients that have gone through specific medications for a longer period of time that make the implant therapy less safe, right? Less secure, and the success rates would go down in those situations. So also we want to show maybe new techniques, new workflows to treating the edentulous patients without implants. So as Tim said, I've been working with VITA for almost 14 years now, and I started in digital dentistry as a CEREC dentist in 2010, and then once I moved here to UPenn, started working with my mentor, Professor Marcus Blatz, on research on different tools for digital dentistry. So today we're going to be focusing more on what we call the Connect digital workflow, which is basically what I use for every complex case, for every full arch case, for every edentulous patient, where of course as a clinician I need to be very accurate in my digital impressions. Also, I need to be very critical of my digital impressions. That's why I say scan and always check your digital impressions. That's what we teach here. And then we will be sharing these to our partners that most likely would be dental laboratories that share this possibility of working with us, or milling centers when we talk about implants, to be able to keep the components original as well. And then the production of those final restorations, whether they are milled or printed, will be made mainly in the lab, and I would be basically a clinician working together in a team approach with an external lab. So this is the workflow that we use for all the complete edentulous cases. It's very important to understand that the accuracy on the intraoral scanners has improved a lot in the last 5 or 6 years. But also it's important to understand that not all the intraoral scanners out there are prepared to help us treat the edentulous patients. Okay, for example, here we have mainly 2 types of scanner. One which is a CEREC Omnicam, which was the previous generation of CEREC, and also we have the CEREC Prime Scan, which is the latest generation. So here we see a change in the technology. As we see also in the center of the screen, the Trios 3 shape and the CEREC Prime Scan are scanners that have confocal microscopy technology. So this technology really makes them more accurate on scanning full arches. I'm not saying that the other scanners are bad, but what I'm saying is that for this specific topic that we are discussing today, a scanner with confocal microscopy technology like PrimeScan and Trios 3 shape, it's what we've seen that works much better. Okay, and there's many options and many new versions of known systems that we try to keep up and try to test, but we really understand that a scanner can be perfect for quadrant dentistry or making 6 veneers from 6 to 11, but that same scanner might be having problems when we talk about scanning all on 6 on 6 implants, or a lower arch for complete denture. So we need to keep that in mind. When we are scanning, independently of what scanner we are using, when we're treating the edentulous patient, we need to make sure that we can retract. For that, I really like to use the Optragate. This is a lip retractor that gives me the ability to have both of my hands free, and I will use my mirror on my left hand to protect from the tongue, to protect the cheeks, to retract properly, and then go in with the scanner and make a linear movement. So the first thing I want to scan is the ridge, to have that horseshoe, which will be the reference area, and then I will start just filling the gaps of the areas that I don't have information. When we talk about the digital denture workflow, we understand that digital impressions are completely mucostatic, so I want to focus on the areas that I have more of the support. When we go to traditional workflows, we understand the importance of recording the movement of muscles and all the different modifications of the techniques that we do to do that. But here, the quality that the characteristic that we have is that with digital dentures, we have a completely mucostatic impression. So the flanges of the denture don't need to overextend, and we will be having a very nice intimate contact between the intaglio surface of the denture and the edentulous arch. Okay, so I like to use the palatal suture to guide me from the ruga to the middle of the palate, and then just connect those areas as I move along to be able to have a nice and clean full arch impression. We published this in a compendium last year on the edentulous patient, and I think it's a very, very good update. If any one of you is interested in getting the PDF, please send me an email or a message on Instagram. I'll be happy to share you this PDF where we go through different modalities of doing complete dentures, some of them milled, some of them printed, some of them with milled teeth, some of them with new libraries of teeth for digital production, and then some research on the full arch and the accuracy that we can obtain, whether it's with a conventional or with digital impression. So I'm gonna use this article today to move forward with this webinar. So in the past, we've been publishing about a digital clone, and this basically is to get all the information that we can from our patient in this initial visit to be able to treatment plan as precisely as possible. But when we don't have any teeth, we don't have references, so the elaboration of this digital clone can be more difficult. So for these situations, we, of course, will be doing the intraoral scans of the edentulous upper arch, of the edentulous lower arch, but then we would use the patient's existing dentures and place some markers, as you see here. These are some radiopaque markers that we can place in the outside surfaces of the denture, and we will take our scanner and scan not only the outside surface of the denture, but also the intaglio surface of the denture. So we get a 360-degree scan of the lower prosthesis and of the upper prosthesis of the patient. And then we can make this buccal scan, whether it's holding the dentures in the hand or placing them in the patient's mouth and scanning the buccal scan as we do traditionally when we're creating a crown with any chairside CAD/CAM system. And with these 5 files, we are able to fully digitize our patient. And the nice thing is that if we use these same initial dentures to do the CBCT with these same markers, it's very easy to correlate the information from the CBCT to the information of the intraoral situation of the patient and the dentures, and then we can move forward. Okay, so this is, let's say, a modification of the traditional digital clone of getting an STL of the pre-op situation, an STL of the digital wax-up, and a CBCT. Here we're getting STLs of the intraoral situation of the patient. We're getting STLs of the existing dentures with the markers on, and then a CBCT file with the same markers to be able to correlate and put all the information together. So this is very important. Later, if there's any questions on this step, please let me know. But this is basically the foundation of how we start moving forward with the digitalization of our patients. So when we talk about dentalist patients nowadays, they all want treatment that require less time. Of course, all patients want to have the procedures done in less surgeries, whether it's just bone removing to create complete dentures, or if it's surgery for implant placement and grafting, they want to have the least amount of surgical interventions. Most of our patients nowadays want to have back their fixed dentitions, but if we do a high quality removable prosthesis, many of these patients can function and feel very confident as well. And of course, the aesthetics and function is of a high interest for all our patients, so it makes our work on a daily basis very challenging. So many times I see this common mistake that when clinicians or laboratory technicians are treatment planning, they focus on the number of implants to determine between a fixed or a removable prosthesis. And I think that this is not the correct approach. The number of dental implants shouldn't be the determining factor between considering if a patient will be working better with a removable prosthesis or if the patient will be working better with a fixed prosthesis. And same thing will happen in the lower jaw than in the upper jaw. We understand that the bone density in the maxillary is less than in the mandible, and also we understand that the maxilla is firmly anchored to the head of the patient, and the mandible is the one that it's in movement, and it's always, let's say, traumatizing the maxilla. That's why we have certain types of syndromes like Kelly syndrome, combination syndrome, and we need to always reinforce the maxilla. That's something very important for long-term clinical success. So what we should be focusing every time that we are treatment planning in the diagnostic and treatment planning phase is the prosthetic space. We need to try to visualize as best as possible what has the patient lost. Has the patient lost the teeth only, but the soft tissue is intact? Let's say a young patient with substance abuse or rampant caries where we need to take out all the teeth, but the soft tissue and bone are basically intact. Or if we have a patient like what you see here, maybe a patient that has been wearing dentures for 10 years and has lost not of course all the teeth, but sufficient soft tissue and sufficient bone. So by being able to visualize the prosthetic space, we will always be having more successful restorations for both removable or fixed, right? As I said, this is everything that our patient wants, so we need to make sure that we take a moment to really diagnose exactly what has our patient lost to be able to make a prosthetic design that really addresses that. So I want you to take a look to this denture that I fabricated around maybe 10 years ago. And this patient came referred to me because I did an all-on-4 to her friend, and she was working very well with the all-on-4, and she wanted a maxillary all-on-4 as well. So as I said before, it always should be prosthetic space management what dictates the therapy and not the amount of implants. So as you all know here, maxillary central incisor has an average length of 10.5 millimeters. Let's say that an implant can be 10 millimeters long. So if we see this configuration, we will very easily understand that maybe an all-on-4 with this type of implants and this number of implants might not be the best structural foundation to restore this patient. And also the amount of bone that this patient has lost and the amount of lip support that we need to provide makes this patient a better candidate for a removable prosthesis with a flange that can help me compensate for that extreme amount of bone loss that if I would try to go with a hybrid prosthesis, for example, or any type of fixed dental prosthesis, okay? I like to use the softwares not only to design. I think these softwares are made for design, but I really like to use them for treatment planning. Because when I have my edentulous patient and I can scan the patient at its proper vertical dimension of occlusion and have a nice MMR, maxillomandibular relation, then I can start by always setting up the teeth first. Always set up the teeth, always try to have those maxillary central incisors in the ideal position, because everything starts from the incisal edge position of those two centrals. And from there, I can take a look and see exactly what is the patient missing. Do I need to have a removable prosthesis? Can I go with a fixed solution? How tall will be these prostheses? How heavy will be these prostheses? And then that can help me select the better material. So these are minimums, just the bare minimums. I'm not saying that you can have a nice morphology on 4 millimeters to create a screw-retained crown. I'm saying that you cannot fabricate anything less than that, because that's the height of the components and the head of the screw, right? Same for a hybrid prosthesis. We need at least 14 millimeters because we have teeth that are 10.5, and we have to design a framework that will be supporting that acrylic tooth as well. So this is important to understand it, and many times a bone reduction procedure previous to the final prosthesis, whether removable or fixed, is needed. If we don't visualize this from the beginning, we might be lost and we might be starting to create a prosthesis that might not be exactly what that specific patient needs. When we talk about the possibility of placing dental implants, of course, we nowadays do a lot of immediate loading, right? So basically we have from the moment of placing the implants, if they have a high insertion torque, we can load those implants that same day, the day after, or as the ITI treatment guide says in the volume 4, which is specific on edentulous patients, we have up to 1 week to load those implants, right, for the immediate provisional. Now with different technologies, we can scan once the implants have been placed, and that to a lab that will design something that is high aesthetic, monolithic, high quality. Then we can deliver it the day after, 2 or 3 days after the procedure, and we don't need to go on the conversion denture protocols that we've been working for many years, right? So whenever we're treatment planning this is a nice slide from Dr. Carpentieri's and Dr. Drago's paper. We need to understand the differences between the maxilla and the mandible. The resorptive patterns are completely different. We're going to have smaller maxillas and wider mandibles after the patient has lost their teeth. The loading patterns, as I said, the mandible is always hitting the maxilla. The anatomic factors, well, we have the maxillary sinuses that are very important to consider and sometimes limit the possibility of implants. And in the lower arch, well, the mandibular canal is mainly the most important anatomical structure to respect and always visualize properly. And then from the aesthetic concerns, the maxilla is more challenging than the mandible, without a doubt. So I really believe that one image speaks more than many words, and really like this these images from Dr. George Sarb book on complete dentures and implant-supported prosthesis. And here's where they explain that the maxilla, as I was trying to say, is stationary and it's not equipped to respond to excessive occlusal forces. Okay, so if we don't have these concepts that I've commented in these first 15 minutes clear, we're not going to be very successful with digital tools, with new products, with new materials, with new software. We need to have those foundation concepts very clear to be able to transition smoothly into the world of digital prosthodontics. And now we will be starting to talk about digital dentures. And why are we trying to move forward with digital dentures? because if you see this slide with my step-by-step to create a traditional denture, there are too many appointments. It's too demanding for the clinician, for the staff, for the patient, of course. And after these 5 appointments, let's say we deliver the final prosthesis, and maybe we need to see the patient for sure at least 2 times more for small occlusal adjustments and adjustments on the intaglio surface of the denture. If the patient, let's say, is cleaning the denture and the denture falls and the denture breaks, or the patient lost the denture by any accident, we basically need to start from 0 again and start the whole therapy. So I think that's not very practical, and that's why the digitalization of the complete dentures is something very valuable for our practices, for our labs, for our patient, because we need to reproduce something that was made. We have the archive, we have those STL files, and we can always print it again, mill it again, or whatever workflow we decide, okay? If we want to go into the digital denture world, we got to make sure that we understand how to evaluate correctly the lip support, the incisal edge position, as I said, focusing on restorative space, properly select the vertical dimension of occlusion where we're going to treat this patient, be able to be confident on centric relation registrations before we move into the aesthetic component, right? So we started maybe around 4 to 5 years ago doing digital dentures, and we've improved what we do since we started. As I said, with intraoral scanners that have confocal microscopy, we were able to start scanning these full arch edentulous patients. One of the most important elements on aesthetic dentistry that Dr. Blatz always mentions is the incisal edge position of the maxillary central incisors. That's the starting point of everything. So I like to use this instrument. It's called a papillometer, and basically gives me a good approximate where I want to place the incisal edge position if I want to shorten the overall therapy when I go with complete digital dentures. Okay, so that's the first thing I'm gonna be measuring. Then I'm gonna do traditional techniques to determine the vertical dimension of occlusion by marking a point in the nose and one in the chin and measuring the distance while the patient is in rest, and then subtracting between 2 to 4 millimeters for the free interocclusal space to obtain my final vertical dimension of occlusion. Once I have that, then I need to make sure that I can have something that helps me correlate the file of the upper jaw and the file of the lower jaw when I don't have any previous denture from the patient, for example. Okay, so as I said, this was scanned with a Trios 3-shape scanner. I'm using the Ultragate. I'm going and scanning the horseshoe, and then I will be retracting and try to scan as more information as I can. Then I will be exporting those STL files, but the lab cannot do much here if I only send these 2 files, because there's no byte registration, there's no MMR. So here it's very important that we find any type of triple tray for edentulous patients. Okay, this one is called a Centric Tray. There are many of these prefabricated disposable plastic trays that we need to know how to use. So basically, I just place some putty on the inside of the upper side and place it in the palate of the patient. And then once we've already determined that vertical dimension of occlusion, I will place some putty on the lower arch and start guiding the patient to close down until we reach that predetermined vertical dimension of occlusion. I will let the material set while the patient keeps that position, and then this is what I'm going to be scanning. So the capability of the intraoral scanner is very important, because I'm scanning not only the intaglio of the upper impression, but I'm going around and scanning the intaglio of the lower impression. So with this, the dental technician in the lab has the ability to make a manual correlation and be able to virtually mount the case in the articulator and start designing the prosthesis. When we're able to do this, we can jump into the trial denture in our second appointment. So instead of being 5 appointments, we can have this done in 3 appointments. So here we will be checking the occlusal stability. We will be checking the relation of the teeth with the muscles, with the smile, with the midline, etc. And if we see that any of these trial dentures is non-retentive, not having a good relation on the edentulous arch, we can always make a wash and improve the detail and then rescan it again and send that back to the lab. So the nice thing about being able to have that centric tray or triple tray for edentulous patients is that our second appointment will be directly a trial denture, so we skip the wax and the rims, and then we can go for the final restorations. So at that point, we were milling the base, we were milling the teeth, and putting these two together. So the good thing what I see here is that we are milling the entire horseshoe, so the amount of surface area that we're bonding to the base is more than when we go with single teeth. But the aesthetics, as you see, are not great, and the area of the connector looks very wide, making this not that aesthetic. So what we really like at that moment was the quality that we can obtain in the intaglio surface of these complete dentures, because we're working on a completely mucostatic impression technique, which is the intraoral scanner. Okay, so we were learning and trying to advance and improve with the results that we were achieving. But most important, we need to make sure that the teeth are in balance with the tongue, with the lips, with the cheeks, and we have a stable reference point, a stable and reproducible centric relation and vertical dimension of occlusion. Then we started to see these type of patients that come for urgent care with failing fixed dental prostheses, with huge mobility. So here we were facing another challenge. How am I going to make here conventional impressions for diagnostics and treatment planning? So the ability of having these type of intraoral scanners are great, because I scan the teeth, even though they are in hypermobility, right? They could come out with an alginate impression, but I'm scanning that. So I'll be scanning the upper arch, scanning the lower, try to get some references between the upper and lower arch. I know this won't be a perfect centric relation registration, but I'm able to go ahead and scan that. And as you can see here, from the first appointment, I already have all the information. This is scanned with the CEREC prime scan and then exported as an STL file and sent out to an external lab. And then in the lab, we are able to virtually remove the teeth. We are also able to reestablish the vertical dimension, because we can open the pin on the articulator on the software. So if I have this MMR and I see that this is collapsed due to the excessive mobility and the lack of posterior support, we will be opening the pin, whatever we need, 2 millimeters, 3 millimeters, to be able to fit properly the new set of teeth and have material for the acrylic surrounding those teeth. And then we can design a new type of digital denture. So this was the first time we did the VITA Vigo Bionic workflow, where we were 3D printing the base, and we were buying from VITA North America the denture teeth. So these are denture teeth that are specially made for digital dentures, where we have the library of all the different sizes and shapes of the teeth in the software, and we can select. We can download that in the 3Shape software. We can download them also on the Exocad software, and I think in Dental Wings as well. And then we will be purchasing the VITA Bionic Vigo digital tooth. As you can see, these ones don't come in a tab with wax. They they actually come in a very particular package where the intaglio surface of the tooth is already air particle abraded. So we can 3D print the base, and then VITA will also provide you with a specific bonding agent to bond the tooth to the base. The base could be printed or the base could be milled, but this is a higher quality of tooth because we're not just milling it from a PMMA. It has more density. It has much more characteristics regarding the texture, the aesthetics. And here, what I'm going to say very clearly, it's very important that the design is appropriate so the pink component covers sufficient structure of the tooth so we can have more bonding surface area. Okay, so that's something important to always consider, that the gingiva part, the pink part, really wraps around that cervical portion of the tooth so you can have a stronger bonding. So here the patient got the teeth extracted, and then we're able to deliver this immediate digital maxillary denture. Okay, and then as I said, there's other combinations that we've worked with. I really like what we see with the milled bases. The milled bases are very dense, are more cost than, of course, higher cost than a printed one, but also have even a better response regarding to microorganisms compared with some of the printable bases. I'm not saying we don't use a printable base, but we use more printable bases for interim or short-term prostheses, and we like the benefits of the milled bases for our final digital denture. So there's flexibility on the workflow. It's nice to be able to have this type of acrylic teeth that already come ready for bonding them to the different bases. Okay, when we started working with the concept of hybrid dentures, we were still designing a framework, milling a titanium framework with mechanical retentions. So then we were able to set up the teeth on top of this framework and process the acrylic. And here we could have a lot of success if the design of the framework was correct, if the amount of prosthetic space was sufficient. But also we all know and have seen that if we have not enough prosthetic space, the bar was not properly designed, then we could have dislodging or loose teeth from these hybrid prostheses, and at the end was something not great for the patients. I always like to have this titanium exposed lingual in the lingual surface, but as you can see on the photo on the right, whenever we have more than 14 millimeters, maybe here we were more towards 16 millimeters on the anterior side, we can have sufficient material wrapping around the tooth. We have enough height for a nice bar design, and these work really well. These were the VITA Physiodents teeth, which I started using and having actually trained with Dr. Eugen End, the creator of this line of acrylic teeth, and these have been working really nicely. These are light frameworks and are easy to repair, so I think that this is a good solution for many of our patients. When we talk about immediate loading, now going to immediate solutions, we need to understand that between 2 to 4 weeks after placing the implants is the most dangerous time, that we need to assure that the patient understands that they need to be keeping that soft diet, right? Because that's where we start to lose the primary stability, and the second stability due to the new bone formation is not there yet. So we need to explain the patient everything from the beginning so they are conscious about the risk. Then I think like 1.5 years ago, almost 2 years, I published with Dr. Blatz a new method of designing these hybrid prostheses. But basically, the initial part of the therapy was the same. Patients with bad quality of dentistry, with remaining teeth in bad condition. So we extracted the teeth, we placed the implants, and then we converted this traditional immediate denture into a fixed immediate loaded provisional. Once we waited for osseointegration, we were able to remove this provisional restoration and then went ahead and did a conventional impression. At that moment, this is around 6 years ago, we were not doing full arch digital impressions at the implant level in this type of situations. So we designed a custom tray that is very helpful to make a open tray impression technique. And this was designed and 3D printed. And then we started setting the teeth ideally. Always start from an ideal tooth position, okay? Never compromise. Always start from an ideal tooth setup. And from there, we start deciding what infrastructure we need for these teeth to be supported. So here, we started working with a newer, at the moment, group of materials called high performance polymers. The first one I was introduced to dentistry was the PEEK for the temporary cylinders for immediate loaded provisionals. That's the polyether ether ketone, but another say family of these polymers like the PEK, polyether ketone ketone, was a material designed for full arch frameworks that could substitute titanium frameworks. And then in this situation, we didn't know much about the bonding to this material of the materials that we could layer on top. So we designed thimble bar design, where we in the software created these single crowns, or these preparations to receive single crowns, and then we combine micromechanical preparation elements with these newer technologies. So here we were working on temporary cylinders because we were limited with the types and numbers of tie bases available in many situations, but now this has improved significantly, and most of the implant systems have great solutions for full arch fixed implant supported restorations. So as you see here, we have the framework, and then we milled single crowns, and for this restoration we selected the VITA hybrid ceramic. Why? Because it's a material that has that modulus of elasticity between dentin and enamel, because it's a light material, and the patient claims that they have a nice feeling with this type of material. It's not so hard. And here Jay Black did a really nice work, not only on the designing and milling of the crowns, but also using the VITA VMLC, which is veneering material light curing, to work on the pink aesthetics. So this is what we were able to achieve: single crowns extraorally cemented to these PEK framework, and then of course taking detail on the adhesive cementation. We want to make sure that we always start with a very clean surface and with a surface that is air abraded on the PEK framework. So we did air particle abrasion at a low pressure of 2 bars. Then for the VITA, we etch with hydrofluoric acid for 1 minute. And after applying the acid in the entire surface and washing very well and drying, we were able to apply a ceramic primer, or basically a silane, for this situation. So the hybrid ceramic is bonded through a silanization process, because it's basically a feldspathic ceramic with a 14% of composite. So it's a silica-based material, hybrid ceramic VITA. This is the clear field ceramic primer plus that it's a silane, but also contains MDP, which is the phosphate monomer that we need to apply to the oxides or the pectin frameworks, like in this situation. This is another use for this primer with MDP. So we apply it on both surfaces, and then we go with the final cementation of these restorations in the lab. The nice thing here is that I have perfect control. I can apply the exact amount of cement, and I can place the restorations one after the other, tag cure, and then remove the excess of cement without having the patient, without working the patient's mouth where there's saliva, even bleeding, and it's more technique sensitive. So for VITA, I wouldn't suggest to create screw access holes. The material has a lower flexural strength when compared to zirconia or lithium disilicates. So I want to keep that nice biodome without creating the screw access hole. But this is a pectin framework follow up with Anatomic single crowns published at 5 years. So now moving forward, we wanted to start working with full arch zirconia as well. And these were also cases done around 5 or 6 years ago when we were mainly transitioning patients from partially edentulous situations where they have been neglecting dental care to an edentulous prosthetic design. And nowadays I wouldn't do this without a full guided procedure where also we were able to mill this from a PMA disc. So the VITA temp is a very nice solution to mill this out. Then we were placing the implants, placing the multi-unit abutments. That is something we use for every single edentulous case. And then on the mill PMA, we capture the temporary cylinders, and we could add also some VMLC after sandblasting and applying the bonding agent, and could improve the quality of the provisional restoration. So after 3 or 4 months, we torqued those multi-units to assure that there was a full integration of those implants, and then we made a conventional impression technique and used the same provisional of the patient to mount the case in the articulator, and then we would be scanning the Artex articulator into the exocad software, and from there we were designing a framework. So here we nowadays have a full assortment of zirconia materials from VITA. Whether you want to use a fully veneer substructure, that's where we would go with the VITA YZ HT, which is a very strong material indicated for full arch solutions that we can layer partially or fully depending on the area. And then most recently we have the VITA YZ ST, which is translucent zirconia made specifically for monolithic restoration. So this material won't have the highest flexural strength as the VITA YZ-T or HT, but it's still strong enough to create 4-unit FDPs in the posterior or 6-unit FDPs in the anterior zone. And then we have the most translucent version from the VITA zirconia family, which are the extra translucent, and these ones have more percentage of yttria, so they have more aesthetic results, but at a lower flexural strength. So it's nice to have these gamma of possibilities, these 3, let's say, groups of zirconia. And if you guys want to learn a little bit more about why are these materials classified in these different groups, I published with Dr. Platz in Compendium a few years ago a short article on the effect of the different percentages of yttria on the zirconia to provide more higher flexural strength at a lower translucency or higher translucency, but with a lower flexural strength. So here the restoration is milled already with a digitally planned cutback on the facial aspect, so we can layer the facial aspect. Here we could use VITA VM9 or Lumex to layer the zirconia framework, and then apply the APC concept technique to bond the titanium bases that go on the multi-units. What's APC? Air particle abrasion, a primer that contains MDP, and a composite resin cement. So same as we do for single implant sported crowns, we'll be adhesively bonding these titanium bases to the full arch zirconia restoration with the gingiva material and the white ceramic on the facial aspect for a better characterization. So when we want to start summarizing, when we treat the edentulous mandible, if you're going to start doing complete dentures, traditional dentures, you got to be very cautious. I wouldn't like to be the first dentist making a set of lower dentures to my patient. I think that 2 implants in the area of the canines with 2 locator abutments is the minimum of care, minimum standard of care, and these can have a conventional overdenture on top and work very well. If the patient has experience wearing lower dentures and I see that I can do something better, then I might consider creating a new denture. Also, of course, if the patient systemically cannot have any implants, not even 2 single implants placed there, so that's where I would consider lower complete denture. When we want to go with a hybrid prosthesis on the lower arch, 4 or 5 implants could work pretty well in most of the cases. And if I want to create a fixed dental prosthesis, trying to reduce the cantilever, I would need 6 implants and have a better distribution throughout the arch. In the maxillary arch, as I said, it's different than the mandible. Here, complete dentures work very well. Many times even better than overdentures. Maxillary overdentures are more technique sensitive, so watch out with that. And if you're going with an overdenture, make sure that you have at least 4 implants and a metallic mesh inside the denture to compensate for that lower density of the bone. That's something very important to consider for removable prosthesis on the upper arch. The upper hybrid prosthesis, I'm not a big fan of the upper all-on-4. I prefer to always try to have 6 implants in the upper arch. As I said, the maxilla is anchored to the head and is always receiving the constant trauma from the mandible. If we are going with a fixed dental prosthesis solution, as I just showed you with the full arch zirconia, at least 6 implants. 8 implants would be the maximum, I would say, but also many implants or a higher number of implants more close together can difficult 2 things. One, the design of the framework and also the hygiene for the patient. So that's why we always start with this digital clone to be able to prosthetically plan those implants. And I want to share this new case that I finished a few months ago where we are doing newer things. So this is an edentulous patient in the upper arch where we started by making the intraoral scan of the upper, the lower, scanning the patient's existing denture. And when you treat a patient that already has an existing denture, make sure that you get the most information out of that existing denture. We can really evaluate the amount of lip support that this denture is giving us, the height of the smile of the patient with this position of the cervical margin, so we can come up with a better solution, with a better prototype. Or if there are things that are okay, we can maintain them and we can have less negative surprises when we deliver the immediate full arch provisional after the surgery. So as I said at the beginning, we will be placing some markers, and then we will be doing the scans, not only of the outside part of the denture, but also on the intaglio surface. In this case, the patient has lower teeth, so we will place the denture in the mouth and scan the buccal scan to have the MMR, and then scan the lower arch. And that way, we can start treatment planning. So here, this is a screenshot from the Implant Studio software from 3Shape, where we can activate the mesh of the upper denture and then use it as a template to start placing the new teeth to do the digital wax up. And from there, we go ahead and start planning the implants. And in this case, for a maxillary full arch, as I said, I try to distribute 6 implants as best as possible. Then we go ahead and design a surgical guide with some fixation pins, and then we can 3D print this surgical guide. Once we've 3D printed the surgical guide, we glue the metallic sleeves to the printed guide, the wider ones for the implant sides and the narrower ones for the fixation screws. And then we can also 3D print these prototype or these new conversion denture. basically we use the part of the palate to help support the prosthesis in its original or correct position. And this works pretty well, very nicely when we're doing a flapless approach. This horseshoe or this provisional is, let's say, in contact with the palate and the rest of the denture by these, let's say, connectors that are very quick to cut and to do the conversion. So we save a lot of time, and we don't need to be cutting out the entire denture. It's just 6 connectors, and this makes it much quicker. So before the surgery, I want to make sure that this is properly seating both the surgical guide and the prototype that we will convert. Now the softwares have the ability to give us different bone density values. So I like to have this information studied before the surgery to under drill and be able to obtain higher insertion torques to be able to load these cases. So it's important to make sufficient pressure of the surgical guide to the tissue, place your anchor pins to fixate your guide, and then use the tissue punch, remove the tissue and drill through the surgical guide, avoiding flaps, avoiding sutures, and reducing the amount of swelling. Of course, we need to always try to keep the area of the osteotomy as cool as possible with irrigation, and then we continue with the placement of the implants. And here a high primary stability is our goal, and it can be achieved because the drilling, when it's guided, it's much more precise than when I'm doing it freehand. So once I finish placing the implants, I will always place the multi-units. The case has already been planned with 6 multi-units, and we have them in different heights and also in different angulations. So we have the straight multi-units, which is a one-piece abutment, and then we have the angled multi-unit abutments. Usually they are around 20 and 30 degree angulation, and they have a screw that will fixate the multi-unit abutment to the implant, and then we will have a temporary cylinder that will be screwed to the head of these multi-units. So immediately after placing the implants, we place the multi-units, and we gotta check that the multi-unit is completely seated. That's why x-rays are very important to take, and then we remove any excess of bone surrounding the implant to be able to fully seat the multi-unit. Once we've done that, then we can torque the multi-units and then place the temporary cylinders, and look how precise our drilling was using the surgical guide, that we don't need to touch at all the prototype, and then we can just go ahead and capture these temporary cylinders at the multi-unit level. So when it's a 3D printed provisional, we need to use a bisacryl material or a resin. It could be a flowable resin, or it could be a resin cement. If it's a milled PMMA provisional, like a VITA CAD temp, we need to use conventional acrylic, powder and liquid mixed. So it's important to differentiate the material that you're using for your provisional restoration. In this case, we aerate the intaglio, we apply the ceramic primer plus, and then we use a resin cement. In the mouth, we place the temporary cylinders. We use a Teflon pellet to cover the screw axis. This is a cleaner that helps us clean the zirconia restorations, the ceramic restorations, or the titanium components. And the nice thing about this cleaner, this is the katana cleaner, it can be used intraorally because it has a lower pH than other cleaners. So it will give me a clean surface, and then I could do the bonding to the titanium abutment, and then remove the whole thing and just cut out very quickly those connectors, fill out those areas with some more flowable composite, and then I can deliver the provisional the same day. What are we doing new? What we're doing new is that once we have this provisional, we can remove the provisional, we can place some scan analogs and scan these prostheses, which will give us very valuable information for the design of the final prototype or the final restoration. So what you see here, it's a new line of components. These are scan analogs. You place them on your immediate provisional and you scan the intaglio surface. Okay, and then you can see here that this is already correlated in the software. And then we can also place the scan posts on top of the multi-units. These are multi-unit level scan posts, and make a full arch scan immediately after the implants have been placed. And then we can send the patient that day with this converted prototype, but we can now go ahead and design our second prototype, which will look most closely to the final prosthesis design. So in this second prototype, we can now use tie bases that go at the multi-unit level, and we can have more volume of material around the component, because that's where the fractures come when we talk about full arches. So we use this slice tool and navigate the entire prosthesis to make sure we don't have a weak spot, and then we will be 3D printing this new prototype. As you can see, the intaglio surface is much cleaner, and then we will just bond these tie bases for multi-unit level prosthesis. Okay, so this is a really nice way to scan the captured immediate loaded prosthesis, and then 2 days after we deliver this second prototype. We correct the midline, we correct the color, and then the patient leaves for the next 3 months while the osseointegration process is made, but we already have all the information. And then once we double check that all the implants have been properly osseointegrated by torquing the abutments, the multi-unit abutments one more time, we can scan the intaglio surface, so the final restoration has a very nice relation with the gingiva for easier hygiene by the patient. So here we share the initial design, and we are able to fine-tune the final design by always trying to have a prosthesis that has a homogeneous thickness and not to have a weak link. And always be sure to strengthen the prosthesis around the areas of the screw access holes, because that's most of the time where the prosthesis fail. Of course, the intaglio surface of a fixed restoration needs to be flat. We don't want to have any type of concavity, so I'm very critical when I'm checking these designs to make sure that we are in the same page, the clinician and the lab technician, to provide the patient with a nice design. We check the occlusion, trying to have centric contact points in all the posterior teeth, and then slighter, less strong contacts on the anteriors. Try to have a group function, not a canine function. And here we can go with a new design of final prosthesis. So for this situation, we would be using super translucent zirconia that is in the medium range of strength and translucency, because we will be combining it with a titanium framework. So the titanium framework is the one that provides us with that very high flexural strength, but we can wrap it with zirconia material that it's made to be monolithic, that it's strong enough, and also it has nice aesthetics. So this is a new prosthetic design, as I said, a titanium framework with zirconia framework on top, and these are adhesively bonded together. This titanium framework, it's made at the multi-unit level, and everything was made with the use of an intraoral scanner. So there's no conventional impressions. The final prosthesis is torqued at 20 Newton over the multi-units that were placed the day of the surgery. So if you want to have full zirconia, you need to go with a highest flexural strength zirconia material. If you want to have a titanium framework, then you can use this ST zirconia without problem, because you're having a strong chassis like a car, basically, that titanium framework. So yes, we nowadays in 2022 can take full arch digital impressions for edentulous patients with intraoral scanners that work with confocal microscopy technology. The two systems that I've validated are the CEREC Prime Scan and the Trios 3-shape scanner. Nowadays, we see a trend on the implementation of photogrammetry, and I would just like to close out by explaining that photogrammetry is very accurate to capture the position of the implants, but if I'm a clinician, I would still need an intraoral scanner to capture the soft tissues and the buccal scans and the bioregistrations and everything. So it doesn't make much sense for me as a prosthodontist. I would prefer to have a highest quality of intraoral scanner, that with that quality, high quality of scanner, I can make a single crown, I can make a 6-unit FDP, or I can make a full arch digital impression. But I know that many labs are using this type of technology, which is still very weak regarding the amount of literature published. I've been doing PubMed searches on these, and we are doing now in vitro testing, comparing ICAM, comparing the PIC system, which are both photogrammetry systems, with conventional impressions and digital impressions. But for now, what I'm using for full arch are the CEREC Prime Scan or the Trios 3-shape. So maybe next time we meet, I already have these final results and can give you some numbers that we all like to hear and see. So it's important that as clinicians, we really make sure that whatever we're going to invest is something that we're going to be using every single day in our practices. And as new technologies come, we're gonna be critical. We've got to see if it's something really better, if it's something really useful for me. So basically, this is the iMetric system, the ICAM. So as I said, right now I'm finishing a study focusing on photogrammetry compared to intraoral scanners and conventional impressions, to be able to validate that workflow, to be able to validate also 3D printed full arch provisionals that we've already been working on this. And as you see, when you go on the literature, there's basically just a few case reports published on photogrammetry or some in vitro stuff, actually without great results. So I just like to, as Dr. Blatt says, don't jump in every train leaving the station. Be critical about the new technologies and really make sure that if you're going to invest in technology for your clinic or your lab, it's something that you're going to be really using hopefully every single day you're in your office, right? So it's 1:07, and I just want to have a few more minutes if there are any questions. As I said, all the publications that I mentioned, if you guys are interested, please follow me on Instagram, send me a message there or an email, and I'll be able to send you the PDF. If you guys have any questions regarding any of the materials we've discussed, from hybrid ceramics, milled dentures with VITA Vigo bionic acrylic teeth, or YZ zirconias, on multi-units or anything, I'll be happy to try to respond to those questions. If you guys have a nice idea of something to test, to check it, I'll be happy to hear great ideas from you guys as well. And I think it would be great to be able to keep in communication. So once again, want to thank Jim for inviting me one more time for the webinar. I try to always come with new stuff, and was glad to have this full new case and something I'll be working this year, presenting these workflows. And as I said, always, I try to always make my education go along with the hands-on component. So stay tuned for more of those coming up. I want to thank Patrick from VITA North America team for putting these webinars series together. And if there's any questions, I got some 10 minutes. Thank you very much.
All right, Dr. Caneo, thank you very much. Very interesting on the future of digital dentistry and particularly digital dentures. So appreciate your work and your testing, the experimental step that you have to go through to determine best practices. Just a little bit of follow-up. The CE, if you're asking about CE, you'll receive an email from our Education Marketing Department that will talk about the CE. We will use the registration information that you inputted for the registration itself. The workshop has been recorded. Give us a couple days. It'll be posted on our VITA Learning webinar media sites, VITA YouTube North America. So please look at those that we have there. We'll post them on our social media sites, so YouTube, LinkedIn, and so forth. If you need to get a hold of a local rep from VITA, here is some information that you can use. If you feel you need to follow up with us on anything that Dr. Conejo mentioned, please do so. You can also join us for our future webinars as well. Dr. Conejo has several more to go for the rest of the year, but we also have others this month and then throughout the summer and then throughout the fall, of course. We're also doing some remote 3-day, 2 hours at a time, 3-day programs remotely, which we'll send you a denture or we'll send you the appropriate models, and then you work side by side in a remote setting, 2 hours, 3 days in a row, or 3 consecutive weeks, and go over step by step as well with the trainer. A hotline here for VITA North America. The help desk here, please email us or get in touch with us if you need more information from us. And of course, Dr. Conejo, thank you very much for that informative webinar. And then we'll get to some questions here. So let me go into the question box and let's just start seeing what we have for our questions and so forth. So somebody's asking about sharing your slide deck. I think they would need to contact you to specifically maybe see about that, since usually most slide decks are very personal to the trainer. But that was from Tim. And then we have for a good edentulous scan, how long does it normally take you to scan each arch?
Yeah, I think that it's easier to scan the upper arch than the lower arch, because in the lowers I have the tongue and the muscles insertions. So what I like before I get started scanning is to kind of have a game plan, right? My scanning strategy. I want to make sure that I always go with linear movements. So I start from the distal towards the midline, and then I continue towards the distal of the contralateral side. It's very important to place those scan posts not exactly in the same direction to help the scanner, and that way the scanner doesn't mix those scan posts from one implant site to another. So if we have these concepts and we place those scan posts, let's say misaligned, not in the same way, then the scanner could be done much faster. I think that between doing the upper and lower and scanning the dentures or the provisional, I would say that could be a 30-minute appointment. But of course, my suggestion, if you're starting with this, try to get a model from any previous case you have, place those scan posts there and practice these linear movements that I'm saying, placing the scan post in this misalignment, so you can see that your scanner is going smoothly. Also, whenever you're doing full arch intraoral scanning, make sure that after you finish one arch, you click File, Save, and export it if possible. Sometimes there's so many data going there that if we keep scanning because we're missing a specific area, and then we go back and then we cut it out and then we go back and rescan, that could cause your software to crash. So this happens. So I try to scan one arch, file, save, and export, then go to the other, and that helps me have less concerns if the software will be computing completely and I don't need to repeat any procedure. Then I separately send the STL files, and the lab has the ability to make a manual correlation or download those STL files, because the software used in the lab is different from what we use in the clinic as a chairside systems.
All right, thank you. That's actually very important. You know, computers only have so much data and working power. So
yeah, and we need to live with that, right, Jim? But we're conscious of that. There's always less problems, right? We think that our computer is going to run perfectly forever, and we keep going 20 minutes with the scanner on. We're gonna, at any moment, we're gonna have some software issues.
All right, so prior to the scan, do you have the patient without dentures relax so that the vascular, everything gets back to normal on their ridges? And
yeah, so this is a great question, and actually I was always concerned, how am I going to do a digital impression for a complete denture, right, when I'm not able to scan a mobile structure in different positions, right? And I had the opportunity to hear Dr. Goodacre, Dr. Charles Goodacre in London at the International Academy of Dental Research, IADR, and he was giving this lecture on digital complete dentures, and he was explaining that the amount of pressure we all do to move the muscles around and everything is not the same between all the operators, between all the clinicians. And here what we basically need to do is focus the scanning on the more firm areas like the ridge, the palate, etc., and then just lift the lip slightly and scan it. And once you scan that area, you move to the front part, scan it, and continue with that. And basically, we just need to have a denture design where we have an insertion for the frenum to be able to move freely, but it's basically the intaglio surface having a nice support and an intimate contact on the ridge. That it's what is needed. Actually, these complete dentures, we don't make a post-dam. It's really not needed, and we see very good results. If you do have unstable trial denture, remember that you can take some regular or light body impression material and make a wash, and you have an extra chance to rescan that to be able to optimize the retention and stability of that final denture when it comes in its final denture.
Do you, just curious, do you do a post-am for a printed denture? I know the accuracy and the fit for milled is very good. What about printed maxillaries?
Yeah, no, so sometimes we actually we don't, and sometimes in the software you don't have the proper tool to do a post-dam if you're just doing an intraoral scan, right? If you're scanning a stone, a cast, then you could do that. But no, it's different working with digital dentures compared to the traditional dentures. The issue, what I see, Jim, with printing is the post-curing. Nowadays, most of the systems have a very structured post-curing method, and that's so important to follow. It's not only the quality of your printer per se or the quality of the resin that you're using, but you need to have a certified cleaning protocol and a certified post-curing protocol for those materials to be really stable. And that's where we were lacking in the past years in 3D printing. Nowadays, I see things getting more structured and a little more specific on that area. But for complete dentures, digital complete dentures, we are not doing the post-dam.
So the slide showing the prosthetic space, you had some minimum inner arch space requirements. Was that for a single arch or a upper lower? Probably for a
that was an
single.
upper lower. I think
Upper lower.
that's a video I did with the in-lab software, which doesn't let me make one single denture. It's say a disadvantage, only upper and lower at the same time. But what I like is to take my centric relation and maxillomandibular relation, and then in the software, if I see that I'm a little bit tight, I open the pin 1 or 2 millimeters, like I would do it with my normal articulator to improve the space, and then try it that way. So that's something we do very common. And there's plenty of evidence showing that if you reestablish a vertical dimension or you augment it maybe by 1 or 2 millimeters, it might be something very, very helpful.
Have you come across any printed resin for permanent dentures that are, I guess, FDA cleared?
No, we don't do printed permanent dentures, and the amount of data out there published from serious sources is very, very poor. I think that they are improving. Maybe our provisional printed prosthesis will start to become permanent, right? But for now, come here and tell you, yes, you can print a permanent denture with the same wear as acrylic teeth. I haven't seen it, and I don't want to sound too fanatic of new technologies. I like to make sure that when I invest and move forward with something new, is something that it's actually better. So as we said, we don't jump in every train.
You did show a slide there that had some printers. What 3D printer do you recommend? Or
yeah, I mean, I've used multiple. I think that it varies between your setup. If you're a big lab, production lab, you will need maybe something like a carbon printer. Stratasys printers that I've seen perform really well. I've been working with some milling centers that I know that they have those type of printers and work very well. Then if you are maybe a smaller lab or a clinic that you have a digital technology there, maybe medium range printers that I'm familiar with, that we have them here at Penn Dental Medicine, could be the Rapid Shape printer. I like that you have different possibilities of materials, but all of them have a code that you can scan the materials to make sure that it's certified for that one. Sprint Ray as well is a printing system that we have here and use. But I think that there's no one size fits all on 3D printing.
all right. So last question. You mentioned about the fracturing around the access screw hole. Have you found that is there a minimum material thickness that they should adhere to in acrylic, or?
Yeah, I would say that the thicker the better when you're working in acrylic or in printed resin. I always explain the patient before I start that the design of the prototype will be bulkier, thicker than the final restoration, because no matter how you produce your prosthesis, whether it's milled or printed, thickness matters in materials. So make sure that you don't have a weak link within that prosthetic design. And around the screw access hole, is important to always respect the minimal thickness warning. That's in the software because of a reason, and many times I see people just click on clicking the minimal thickness warning. You will be having more tickets for the lottery of winning a fracture, right? So respect your minimal thickness warning, respect parameters, and design defensively. This means that if you're using materials with a lower flexural strength, you want to augment. I cannot give you a number because we are talking here not of like a space like a connector. It's different due to the different shapes that we have. Just these will are general concepts to consider.
All right. So thank you very much for your time, Dr. Conejo. Appreciate all the information. Any last words you'd like to share with the audience?
Yeah, no, thank you, Jim, for the invitation one more time, and feel free to contact me if there's any other questions. And I'm heading back to the clinic, but enjoy your day, and thanks a lot for sharing this time with us.
All right. Well, thank you very much again. Thank you, everyone, for joining us today. It was a very informative, very uplifting program today about digital dentures and the future as well on what we're seeing today in the digital environment. So thank you for joining us. Thank you again, Dr. Conejo. And this will end today's webinar.